One of the colleagues who has been very much involved, at least during the last years at meetings, is Bob White, and we are very glad that he could come just for 2 days. He has to go back tomorrow. He came yesterday, and for this meeting, and he's I think one of the leading neonatologist working on the environment and architecture of the neonatal ward, and I've heard him before several times, and he's really very interesting talks. He's professor at University of Notre Dame in Indiana, and he is at South Bend. So please.
Yeah. Well, thank you, Hugo, for the introduction and the invitation. As Bjorn said, Karolinska for many years has been the shining light on a hillside to many of us in the United States. From the time we heard about Nobel Prize winners here many years ago to now, we have followed what we learned from Karolinska. So Bjorn asked me to speak about the next big ideas in NICU design, and I have no conflicts. Most of all, what I would like to disclose is that I'm not the expert in this. Bjorn invited me to come from the United States to tell you what I learned from all my friends in Europe. So I'm here to tell you what I learned from Jack in Brest and Dominique in Brussels and Uwe in Uppsala, and most of all from Bjorn and his team here at Karolinska. So this will not be so much a lecture as a seminar. I'll place some ideas out there for us to talk about, and then I would like to hear from all of you what you are doing, where you're headed with NICU design and operation. And if we finish a little early and give a little extra time for the Karolinska experience, so much the better. So this list of next big ideas, when I presented it at the Gravens conference a couple of months ago, was full of radical ideas, things that people in the United States are just beginning to think about. I'm a little embarrassed almost to present these as the next big ideas to this audience, because many of these things you are doing and have been doing for many years. But we can talk about what the implications are for design. Many of you will be building new units, and even if you're not, there are many operational implications that we can talk about. So the first of these ideas is couplet care, and we'll talk about each of these individually. Family integrated care, which is the term which Shuli has given it at Toronto, but I know it goes by many different names. So we'll talk about the concept, but I'm using that title. Group care is a concept that is more relevant in the United States than it is here. It's the concept that many of our babies are living on their own without their families. Their families are not spending much time with them, and we don't want to put them off in a private room by themselves in isolation, so we need to talk about how we care for them together as a group. Specialty care is a concept that is beginning to be implemented not only as a design concept, but as an operational one. Care in other settings, again, is something that to a large extent I have learned from those of you here in Europe who are already doing, for example, this home care of our 34 and 35 weekers who just need a little bit of gavage feedings. And then I thought we should talk for a few minutes at least about new technology, which will change much of how we operate and therefore what the design should be. So let's start with couplet care, and this concept is that we should keep mothers and babies together at all times, but most especially in those first crucial hours and days when both the mother and the baby and the relationship are most vulnerable. It's happening here in Sweden, and since we learned about this in Sweden, some centers in the United States have started to utilize couplet care. Ours is there on the list. We've been doing it now for 3 or 4 years in our existing unit using concepts that we brought home from Sweden. So this can be done in many existing facilities, and Uwe was one of the ones who helped us understand this when he moved chairs out and brought beds into an existing space and began to do couplet care there at Uppsala. There are some operational considerations, more significant in the United States, I think, than in Europe. But in both places, the idea of who's going to care for the mother as a patient, it may be midwives here, it may be mother-baby nurses in our setting. It requires cooperation and collaboration in any case from our obstetrical colleagues. The ideal for this is rooms that are specifically built to this purpose. So in our new unit, which we hope to be occupying in about a year from now, these are the rooms that we are designing. We have, in addition to these, many single-family rooms. We'll have 21 single-family rooms, which will have a bed space for the baby, and then a suite-type arrangement similar to what is present at Huddinge, for those of you who have seen that unit, where behind sliding doors there is a bed space and a shower and a work desk for the family, but those can be opened up so that the family and the baby are together. Those will be our single-family rooms. These rooms, we will have 9 of these, and they will be designed so that we can take care of the mother as a patient, so that when she and the baby are brought from the delivery area, they will be together, not separated at any point, unless the mother herself requires critical care. Then she will have to go to intensive care. But every other aspect of the mother's care can be provided here, right next to her baby, no matter how sick the baby is. So we can do these for the most critically ill babies, even on high-frequency ventilation or therapeutic hypothermia, whatever the need for the baby will be, we can do in this space. We hope eventually even to be able to do vaginal deliveries in this space. So even in the delivery process, we will not have to move the mother and the baby from the delivery area to the NICU. All of that hopefully will happen, but that's another step with our obstetrical colleagues that we will have to take in the future. But we're designing the space so that that will be feasible. We are designing these as multi-purpose rooms, so we have many other aspects that we hope to be able to provide in this space. If we have twins, we have 2 fully operational head walls. We can take care of critically ill twins if necessary, and still have the space in back for the family. So you'll see in the back end of that room there is a sleeper sofa and a full bathroom for the father in the case that this is couplet care, but for the mother and father in the case that it's being used for twins. We can use it for kids who might need a very large amount of equipment. The child with therapeutic hypothermia, for example, if they're here beyond the time that the mother has been discharged, the mother then is no longer a patient, and we have more space in that room to use for our therapeutic hypothermia equipment, which right now is very large. We're getting a Ticotherm, so it will be more compact, but there's also a continuous EEG monitor. For some kids, there's nitric oxide and high-frequency ventilation. When we need all of that equipment around the bedside, we will have larger space to do that. So these rooms are approximately 40 square meters, whereas our single-family rooms will be 30 square meters. We can also do group care there. I'll talk a little bit more about that, but this is the concept that we have. Babies whose families are not in attendance very often, so we can put several of them in this space. If they're intermediate care, often out in cribs, we can care for them in a space together rather than putting them into a single room. And then hospice care is the term used in the United States for children who are being anticipated that they will die in the not too distant future, and we are withdrawing support or at least reducing support for the babies. And often families want to invite in 12 or 15 friends to say goodbye to the baby, these rooms will be large enough that we can do that. So this is, I think, a new type of room, and we are hoping to get experience with it and be able to give that back to those of you in Europe that started us along this idea. Family integrated care is the concept that takes family-centered care one step further and says, not only do we want the family to be here interacting with their baby, but we want to give them the responsibility of caring for their baby in many regards. So feedings and ventilator management and adjusting oxygen concentrations in the baby on CPAP are things that we can teach parents to do to a large extent. There certainly are specialized skills that will only be preserved to the nurses or the physicians, but there are many things that we're doing for babies that parents could do themselves. And fathers in particular love having something to do. They feel helpless in the typical situation if they can't help fix their baby. And to give them this additional responsibility of direct care of their baby is something that I think fathers in particular appreciate, but mothers too. It gives them a sense that they are actively helping their baby at a time when parents feel so helpless and frightened. So this specific concept was introduced by Shu Lee in Toronto. All of Canada has adopted it now. I think most of Australia and New Zealand as well. And he's teaching people in China, in the United States. It's not the only concept. Many of you are doing some of this already. I know Dr. Latonen in Finland has introduced something similar to that. So this is a concept that I think, again, is where we will be headed in the future, where families will not only be present and holding their baby, but they'll be actively participating not only in the care, but also in the medical decision-making, to the point that we will now be much more collaborative in all of that process than we have ever been before. This does have obvious operational implications, and it certainly can be done in an existing unit, but if you are building a new unit, the design implications are evident as well, that we're not just providing a space for a family to be here. We want them to be actively involved, and if we're going to encourage them to do that, we really have to take care of their personal needs as well. So this is a properly designed room that allows the family to live with us for weeks or months at a time and be at their best. They have to be as functional as a nurse or a physician would be throughout that time. In order to do that, they have to have their needs attended to. This is not a new concept. Our mentor in Great Britain, Nick Roberton, pointed this out many years ago. And as you read this, you realize how far we strayed from this concept in the 80s and 90s and are only now coming back to that. So the idea that how we did things in the past was the way they should be, and that we need very strong evidence in order to change these practices that we adopted in the 80s and 90s, I think is wrong thinking. And certainly we need evidence, and most of that is being generated here in Europe, not in the United States. But I think where there is an absence of evidence, there is not an absence of logic and need to understand the role of the parents. So I don't think we need to apologize for moving forward on this front, even though we don't have as strong evidence as we have for, say, surfactant or antibiotics. Group care is a concept that I think is not so important in Europe. Your social supports for families are so much better than in the United States. But at least in the United States, it is very common to have babies whose parents are present for sometimes not at all, but very often only 1 or 2 hours a day. the developmental needs of those kids is substantial, and I don't think we understand it very well at all. We know about NIDCAP. You all are the experts in that and provide developmental support in that regard, but NIDCAP still, of necessity, talks about human interaction with babies, and that's great. But in the best of NIDCAP environments, babies are not getting direct human interaction most of the time in the United States when their parents aren't there, or in any place where their parents aren't there. When staff are interacting with them is still a minority of the time. And they're asleep a good part of the time, so that's okay. It's not that somebody needs to be handling them 24/7. Yet we know that babies learn even during sleep. Bill Pfeiffer at New York has demonstrated this very nicely, and we know this happens in utero as well. So what is the environment that we should be presenting? What is the taste and smell and auditory and movement, kinetic environment that we should be producing in our NICUs for these babies? It almost surely is not what we currently give them in incubators. And so we need to understand this much better. So we have friends in France who are looking at this. We have friends all over who are exploring these topics, and we need to learn much more. But at least what we know from work that Terry Ender did when she was in St. Louis is that we can't leave these kids in an isolation room, in a private room that is so beautiful and so well designed and so perfect when there's a family there. When the family is not there, it becomes an isolation chamber. So we need to design these rooms that have these spaces for multiple kids and then understand what is the best environment to present to them. These additional considerations are ones I have alluded to, and maybe I won't spend much time on them here because I think it is more a United States problem than a European issue. For specialty care, I think this is a concept we will come to embrace before too long, but the first generation of neonatologists finds this a difficult concept to get our arms around because we want to be all things to all babies. And there has been a time through our career in the first generation where we could be the expert at both at pulmonary care, at nutrition, at neurocare, because what we knew about those things was pretty straightforward, pretty limited. But just as neonatology broke off from pediatrics because no longer could pediatricians be all things to all children, I think neonatology is reaching a point where we cannot be all things to all babies, at least in the high acuity settings. We're going to learn so much about the brain that it won't be possible for every neonatologist to provide perfect care for every baby who is at very high risk for neurological complications. And it's not that all of us shouldn't learn as much of that as we can and incorporate it into our practice. It's just that if you're in a big unit with many of those babies, there's something to be said for specializing the care not only on the neonatology side, but also on the nursing side. There are skills that nurses will need to have in one setting that won't be needed in another setting. And the nurse who is really wonderful at taking care of a baby who's 500 grams might not be the best nurse to take care of a baby who is now a feeder and grower. She may have different desires, different skills, and we need to recognize that. So I'm not pushing this concept as something we should all divide up into these specialties, but I do think we will find that there is benefit to identifying certain expertise levels and having our units operated and designed in such a way that recognizes those needs. And what the post-surgical, the kid who's just recovering from cardiac surgery will need in terms of the optimal environment will be much different from what a 500-gram preemie will need. We need to look at the developmental requirements, of course, in each kid, but one will be a term baby, one will be a 26-weeker. Those needs will be very different, and right now we're taking care of them in an environment that's not quite different at all. And then care in other settings. And one aspect of this, the care of feeders and growers who are ready to go home, except for needing gavage feedings, is again something you're far ahead of us in the United States. And we need to adopt many of the practices that you have, but to a large extent it comes down again to the social supports that we don't have that you do, that we should. Narcotic abstinence syndrome is something that I gather you see less of than we do. Maybe I could ask a show of hands. How many of you have at least one or two babies in your unit at any given time going through withdrawal? Very few. So if we were in the United States, almost everybody would have their hands raised, and most of them would say, one or two, you're lucky if that's all that you have, and we've got 8 or 10. So it's a much bigger problem in the United States. But I will at least mention the concept that in that setting, to admit those babies to the same unit that is occupied by 500-gram babies and post-surgical babies, and nurses who are really tuned in to the needs of these critically ill infants, and then to take a baby with narcotic abstinence syndrome and put them in the same environment with the same nurses is just the wrong place for them to be. That's not the environment they need. That's not the kind of nursing skills that are required for their care. And yet, our NICUs are filling up with those kids, and people are building new beds so that they can take care of those kids. And we need to rethink whether the NICU is even the optimal place for that care. So the conclusion then is that this will be a very different world in many ways in the next 20 or 25 years. If you're building a new unit, you need to understand where those changes are coming from. The operational aspects of all of this are considerable as well. And whether you're building a new unit or operating your existing one, you need to think about many of these changes that are coming. We haven't talked so much about the new technology, but I think we will have very exciting new technology. We're going to have, sooner or later, technology that will tell us what's going on in the baby's brain real time. This is long overdue. We know what's going on real time with the heart and the lungs, and not for the brain. That's just scary, that everything that we do with our intervention, we only know the impact on the brain 18 months or 2 years later when we do developmental follow-up. If we're lucky, Heidi Alves has taught us how to gather some signals from the baby, maybe about how they're tolerating it, but it still is so removed from the direct window into the brain that we would like. But I don't think that's going to last for too much longer. Lena and her colleagues with continuous EEG monitoring are teaching us more and more about what we can learn with that technology. Most of you are familiar with near-infrared, where we can see cerebral perfusion. We're going to get much more of this kind of technology at the bedside. Imaging, likewise, is going to be much more accessible. MR units that are freestanding in the NICU so that we can get an MR of a baby's head or lungs or abdomen at any time we need it, day or night, in just a few minutes, the same way now we get an X-ray, I think will be a reality in the next 10 to 20 years. So the technology is going to change things dramatically as well, and we need to be prepared for that, both design and operationally. Okay, so those are the ideas that I can think of that are coming. I'm very interested to hear from all of you what you're doing with couplet care, family integrated care, with any of these other ideas. Where do you think the changes are coming from? So I'll stop now, and we're open for questions and suggestions and comments.
Thank you very much, Bob, for this very good introduction to the discussion. We have actually plenty of time, and we haven't really had time last night to discuss how to do this this morning session. Do you think we should have the Karolinska experience as before
sure.
the discussion?
Yeah.
And then I would like you also to come back a little bit about cost-effective things, because I know you have been very much involved in it. I think Bobo will mention it in his talk, but you will not be here in the afternoon. So I think maybe it would be good to discuss that as well.
Sure.
But maybe, would that be okay with you if we have the Karolinska experience, just like a sort of a illustration on how we have developed so far and which directions we intend to go to. And so please, could we have, you have got your microphones already. Yeah, thank you. So now, Hugo, do you want to introduce? Yeah. Yeah, I'm sorry about that. We have a long relationship. Fighting all the time.
No, because I would like to ask Bob a few questions, but
Why don't you do that then?
no, because I think the study by Pineda and Inder is very intriguing, and there has been some criticism. Just to inform you, so babies who are in single rooms, they seem to develop language slower, and also they could also see by a functional MR that there were differences, and they did seem to mature as well. And you can also compare it if you are in the womb. I mean, if you have you any comments on that?
Sure. So I think there were some criticisms of the study design, but I think their evidence is probably strong enough, particularly when you add to it the evidence that Betty Vore and her colleagues at Rhode Island showed that if you expose babies to parental conversation, if you just teach parents to talk to their babies and read to their babies, that their language is advanced at 18 months. So I think we've seen both sides of that, and this fits in very well with what we know from Betty Vore's group, that babies need that language stimulation and we know that in the third trimester, the auditory part of the cortex is where the most rapid growth is occurring. And it is a use it or lose it sort of synaptic development. From your textbook, I show this graph when I give that part of the talk about what's going on with the synapses and where it's going on. So I think the evidence is strong that babies need language stimulation during the third trimester.
And they actually get it in the womb.
Yes,
I mean,
absolutely.
we know from work together with Pat Cool that the Swedish babies learn Swedish vowels. They prefer the Swedish U, and the American babies prefer the English E. And there's a German-French study showing that French newborn infants cry in a different way than German infants. And the contour of the cry due to the language exposure.
Yeah, and they can recognize their mother's voice. So
yes, certainly.
Probably all of you know this study, but I just love saying it again, that if you have 3 women sing lullabies to a baby on day 1, they can pick out their mother singing the same lullaby as 2 other women. That degree of discrimination is present in a baby who's been in the womb throughout the third trimester. So it's a very well-developed skill that they have, that they are capable of. But if we put them in an incubator in a private room, there's no chance for them to get that.
I just want to make a comment on withdrawal. So the parents ask for that, or can you explain a little? Because I got a paper I'm an editor of Acta Pediatrica, and they're proposing that there should be a hospice for newborns when you have given up really to resuscitate them and to give them sufficient pain relief, and also a better environment for the parents.
So I'm not sure your question. The setting in which we most often have that is a baby with multiple congenital anomalies that are something that most often the parents do request, but sometimes there really is nothing we can do for the baby, so it is not even a decision we ask the parents to make. So a baby with hydranencephaly, for example, we would not put that baby on a ventilator to start with, and so it's not a request for the family to withdraw it. But I will say that there are places in the United States that might do that and still might come to a decision about withdrawal.
But what about a 22 or 23 weeker with grade 4 bleeding to the ventricle?
Yep, that is a situation that does occur, and so if the family does request withdrawal of support, then that is a situation where if they want to invite many other family members in and do that together as a family rather than in private, we try to accommodate that.
And if you don't do that, they can sue you.
Yeah, that's true.
Any more specific questions to Bob? And then we have a more general discussion after the next talk, but maybe there's any more specific question. Okay, then we proceed, and maybe you can come up after